For my final performance at Derm 2025, I have the privilege of talking about an area that is so near and dear to my heart, something that I think defines us as a specialty, and that's off-label use of the plethora of medications within dermatology and beyond. And so for the next 30 minutes or so, I'm gonna go through a litany of different disease states that challenge us, that challenge our patients, that impact quality of life, and provide you with some tools to employ literally next week when you see these patients to hopefully get them to a better place and hopefully feeling better about living in the skin they're in. These are my disclosures. I don't think they're probably very relevant to anything I'll be discussing. So we have to embrace the tsunami of disease states that literally have nothing, or for various flavors have nothing. And so I've divided this up by reaction patterns, and we're gonna go through some diseases, which no question do have some approved indications, but there are few and far between. So let's start with something common and simple, seborrheic dermatitis. And I think one of the challenges when you have a disease state that is so ubiquitous, affects over at least 10 million people in the US, probably more. And this goes back to an earlier statement I made in that when you have a drug indicated for something, you start to learn so much more about the disease state, and not just about the underpinnings of disease, but also the burden, the impact. And so thanks to having indicated medications now, we are learning so much more about seborrheic dermatitis. But sometimes topicals are not enough. Sometimes we need to get creative. And if we look in the literature, there's actually a substantial amount of literature looking at azole antifungals, which, as you can imagine from my previous lecture, I have mixed feelings about given the rise of resistance to azole antifungals. Interestingly enough, if terbinafine would be effective for sebderm, then sebderm really shouldn't be driven by malassezia because terbinafine has no impact on malassezia. So that gives us a little insight in that this probably being more of a true primary inflammatory disease rather than there's over-colonization, there's an inappropriate reaction to something that normally lives on the skin. But I'm really gonna hone in and highlight low-dose isotretinoin. This has really gained favor in the rosacea world, but also in recalcitrant seborrheic dermatitis. And when I say low, I mean we can go really low. So in this one systematic review, on average, patients would be on less than 10 milligrams a day. Now you can imagine, well, how do you do that? Well, this is on average, maybe you're on 10 every other day, 10 every third day. But clearly a very low dose that will minimize the expected adverse events such as the dry lips that everyone's probably experiencing thanks to the lack of humidity here, dry eyes, and some of the lesser appreciated side effects. Now, in a more recent study that literally was just published a matter of weeks ago, this group, and I'm not really sure how they got this funded, truthfully, because no one's gonna pay for this, compared 10 and 20 milligrams a day. And they found that the 20 milligram a day group did do better. Again, this is a much lower dose than we would ever consider for nodular cystic acne and can be used ongoing. So something to employ when you have to reach in your back pocket when a patient's not responding to standard approaches. I love me some lichen planus, and I think, if I have to really reflect for a while why I like this disease so much, I think certainly it's one, we got nothing for it. It's kind of like an ugly stepchild in the corner. No one's paying attention, but it's there. It's out there. It's maybe as high as 1% of the US population, and it is incredibly disabling. We hone in on the skin disease, but we always have to ask, let me look in your mouth. Do you have any things going on in your mouth? Gums, buccal mucosa. Let's take a look at the nails. Let's look at genitalia. I can't hit on this enough. So many of the diseases we take care of can have these kind of subtypes or these other flavors. And we talk about psoriasis, nail inverse psoriasis, sebaceous psoriasis. Same deal with lichen planus. If you see lichen planus, please make sure to look in the mouth, look at the nails, and ask about the groin. Don't just rip their pants down. That would be an HR violation and many other things. I have to throw that out there so someone doesn't come back and say, hey, you told me to do that, creeper. So, got a very loud laugh from the back, thank you. So, the good news is there's a lot of data out there about historical off-label offerings. First line, no doubt, for more generalized disease, disseminated disease, would be oral retinoids. And I use these a lot, though I will say I'm using them less and less thanks to some of the newer off-label options. So I have some of the dosing regimens here. Acitretin does not have iPledge. So a little easier to use, but you're probably not going to use it in women of childbearing years, but that opens the door for others. But I've used Isotret. I've used isotretinoin for lichen planus in as young as 9 years of age, and it melts it away, but it obviously comes with some monitoring baggage. Obviously, immunosuppressants you can think of, probably the most data with methotrexate, even mycophenolate mofetil. Antimalarials can be useful. I haven't found them to be super useful, and even dapsone. Now, oral lichen planus, while affecting a small body surface area, and I think Dr. Rosen really hit into this, it could be so unbelievably painful and disabling. These patients can't even eat. Surprisingly, doxycycline could actually be quite helpful for this. I usually will give 100 milligrams twice a day for 6 months, and then we go down to the sub-antimicrobial dosing, so we're not making the newest superbug. I do sometimes give pulses of prednisone because they're so uncomfortable, but the other things that we think about are in the same vein as we think about with cutaneous disease. So here's some examples of acitretin kicking some LP butt. 6 weeks of acitretin 20, that's another thing. And I had an example of this just recently where I inherited a patient in resident clinic, and the patient was on 10 milligrams a day of acitretin and was doing like a little bit better. And the resident was like, well, we should probably switch to something else. I'm like, or we could actually give them a therapeutic dose of acitretin. And so we bumped it up to 25. I am absolutely fine with you starting at 20 or 25 milligrams a day. When you cross 25 for the day, that's when you start to see hair thinning and kind of like waxy palms. But I've gone as high as even like 40 or 50 milligrams, and that's okay for short periods of time. Here's that same patient with significant improvement. Another patient with a darker skin tone, and you have to remember, one of the reasons why you want to be aggressive with this disease is where is the inflammation living? It's right at the dermal-epidermal junction. That's where your melanocytes are. So you're going to get induction of melanogenesis and injury to the basement membrane zone, causing dumping of melanin into the dermis where it doesn't belong, creating a tattooing effect. Now, there's been some evidence that IL-17 is implicated in the pathophysiology of lichen planus. Not so surprising, given it's in the same kind of family as psoriasis. So I've been playing around, dabbling a little with some of the IL-17 biologics. So this was a patient with nail psoriasis, actually misdiagnosed as psoriatic nails, but we did a nail matrix biopsy and sure enough saw lichenoid infiltrate. Granted, nails take a long time, and this is where setting expectations will save you a lot of pain and anxiety, because if you say, hey, I'm going to start you on something that I think is going to work, and they come back a month later and nothing's changed, you shouldn't be surprised, but they might not be very happy. Fingernails grow about 3 millimeters a month. Toenails 1 millimeter. Any nail things I'm doing, I always say that to the patients. It's like hair loss. It's like watching grass grow. It takes a very long time, but if they put in the time, if they hang in there, they will see improvement. And these were her toenails, but notice, obviously taking a bit longer to get there because toenails about a third the rate as fingernails. Now, this was a case report by Jason Hawkescrew, which I really didn't understand how this makes sense because we don't think about lichen planus as a T2 disease. To be fair, also looking at this picture, this doesn't really look like lichen planus, but this was biopsy proven. And within 2 months using dupilumab off label, this patient had significant improvement. So I said, okay, Jason, I'll bite. Let me try this out when appropriate. And so this patient who was pregnant, who had extraordinarily pruritic lichen planus, who really was willing, if not pregnant, to be on something systemic, and probably needs something systemic. I was like, all right, well, I have registry data about dupilumab. Let's give it a go. And she had significant improvement. This is an N of 1, but certainly something for us to explore and something easy for us to use. Now, I know I'm talking about systemics, but I want to give a nod to topical ruxolitinib as it's plugging along in terms of the FDA approval pipeline. So we may have the first FDA approved anything for lichen planus in the near future, and I have used this in my practice as well. But what about orals? So I think it was said very poignantly by, again, Dr. Rosen, that all lichenoid things respond to JAK inhibitors, and I would absolutely agree, and you'll see this several times in my talk. So this was a patient who had failed a couple other systemics, actually failed acitretin, and put her on upadacitinib, 15 milligrams for 2 months, completely clear, was itch-free in a matter of days. This patient initially responded to an anti-IL-17 until he didn't. Moved over to upadacitinib in 2 months, itch-free, impressive resolution of these kind of, not purple, but more almost like jet black plaques to more flatter and lighter patches. Now I mentioned oral lichen planus, small body surface area, huge impact on quality of life. This patient had failed anti-IL-17, had failed oral doxycycline, so I said, yes, it does work. It doesn't work for everyone. We tried doing some topical steroids, but never really worked out. I couldn't get the triamcinolone paste. We did clobetasol ointment and gel, and she said just like swashed around in her mouth, and she didn't really like it. And she loves spicy food, and her diet consisted of smoothies. And so I started actually on upadacitinib 15, did a little bit better, and then I bumped her up, and within 1 month, tremendous improvement. What I like here is, you saw this in the oral lecture yesterday, that kind of weird, almost like plaque-like changes on the tongue, consistent with oral lichen planus. You could see it here too. Again, after just 1 month, significant changes. And when she came back and I walked into the room, the first thing, before I even had to say, hey, how are you doing? She goes, guess what I ate last night? I'm like, is this like a trick question? What's going on? Her daughter's in there giggling. I'm like, shut up. What is going on here? She goes, I had super spicy pad thai, and I realized this isn't pad thai, but like, I was just Google imaging, whatever. And so I was like, oh, I'm like, I didn't realize pad thai is spicy. It's not supposed to be. She goes, well, I asked for it to be spicy. So obviously a biomarker for success. So she was able to eat food she likes and go off their life, and she's still doing great, and this is many months later. Okay, discoid lupus, kind of like a lichenoid disease. You get an interface dermatitis, extraordinarily deforming. Technically, hydroxychloroquine is approved for discoid lupus. It is in the product insert. And so it is going to be first line. And actually there's this wonderful paper where the title said, why all lupus patients should be on hydroxychloroquine. And it's kind of a trick question because they really should be. However, for many, it is not enough. If you look at the historical off-label offerings, yes, first things first, photoprotection, please stop smoking, topical steroids, intralesional steroids. In more recalcitrant disease, as I mentioned, I probably even limited, I would get them hydroxychloroquine, as there is data to show that it can prevent seroconversion. As high as 20% of patients with DLE will turn into SLE, based on some of the studies out there. So I will without thinking twice, put a patient on. I try to stick to under 5 mg per kg of body weight, and sometimes even go lower than that to limit the ocular toxicity. But then we're going to talk more about severe disease, like I showed you in those pictures. Mycophenolate mofetil, methotrexate were my historic go-tos, but we got some newer things available to us off-label, but hopefully coming down the pike. I did want to throw this slide in though, because think about who is our quintessential DLE patient. It's going to be more often a woman than a man, and it's going to be someone of childbearing years. And so we have to be thoughtful. How are we going to manage this in someone who either A, is pregnant or is thinking about pregnancy down the road? There is some nice data in the SLE world showing that it's more dangerous to take someone off of hydroxychloroquine than keep them on during pregnancy. So I personally have no issue doing that. Topical steroids, fair game. But then you start to get into second line. I would feel more comfortable giving IVIG, not dapsone, in the setting of pregnancy. But you have to think about, again, what is the harm of doing nothing? What is the harm to the fetus if we do not treat the active disease? This is in the handouts. I'm not going to go through it. It goes over what are the pregnancy levels for different medications we would use for DLE. What I'm very excited about is anifrolumab. This is an interferon receptor antagonist. It is approved for SLE, and I've been able to sneak in a little DLE too. But in their pivotal studies, they did look at skin disease as well. And it works. This guy had failed methotrexate, ustekinumab. Plaquenil clearly was on board long ago. One dose, his itch and pain was gone, and we already see some resolution of that erythema. I think another hot area, which I'm going to talk about, would be for a patient who maybe can't go to an infusion center. You're not going to get covered, and I think we'll see this in our armament relatively soon. So this is a patient who walked in and goes, I have hair loss. And this is what I did in my mind. That's hair loss, all right? So what can we think about here that we can literally reach for our sample closet? So deucravacitinib is an oral TYK2 inhibitor approved for plaque psoriasis. The head-to-head was against, which you just heard about, apremilast, and it was superior to apremilast, but it really hasn't found its place, I think, in our wheelhouse. And I think we know the psoriasis market is kind of crowded. To me, this is going to be its place to make its mark. We already have some really nice data from clinical studies, but in my own hands, I have seen this to be a game changer for DLE. So there's our baseline, There's 1 month and 3 months, even getting some hair back. And she continues to certainly improve. So to me, we have this right in our closets down the hall. I think JAK inhibitors will also play a big role, but this can even be an easier sell given the safety profile. Okay, when we think about vesicobullous diseases, the first question is, where is the split? Is it subcorneal, intraepidermal, subepidermal? And where that split is will define what it looks like clinically. It is very linear. So with that in mind, if a patient's saying, I can't wait to pop that blister, and it's been there for a while, that gives you some insight in terms of how tense it was and probably where that split was, and it helps you with your differential diagnosis. But I'm actually gonna focus more on acantholytic diseases, which fall into this category. Acantholysis meaning things fall apart. So the first is going to be transient, it's not transient at all, acantholytic dermatosis, also known as Grover's disease, which for some reason people have to name things after themselves, but we are moving away from it. Has nothing technically approved, and this could be extraordinarily disabling and extremely pruritic. If you look to the literature, this is probably the largest study ever performed to date looking at what's been used. And it's things that are pretty obvious, topical care, topical steroids, antibiotics. None of them come with a lot of, supporting evidence to rationalize using these ongoing. Now, if you think about antibiotics and antimicrobial resistance, we want to be purposeful. We do have a sub-antimicrobial dosing of doxycycline. We just saw the emergence of a low-dose oral minocycline enter the marketplace for rosacea. And we have narrow-spectrum antibiotics, which can be used ongoing. Actually, we have data past a year showing no impact on antimicrobial resistance. So I do use sarecycline in my practice. But my real go-to, of course, as I mentioned before with Sebderm, is going to be isotretinoin, and typically low dose. Now, thinking about that transient piece, it's really referring to it comes and goes. It's usually worse during the summer times. So I will have patients cycle through a couple months of isotret, they stop. It comes back, we go back and forth. And especially in the typical patient population, and you can imagine what that is based on what this is called as the itchy old man disease. So very easy to use in this patient population. If you think about it, things are falling apart, water's getting out, foreign material's getting in. It's almost like a fake eczema or atopic dermatitis. And so we know that the inflammatory environment is more T2, which then lends itself to reach for things that go after T2 inflammation. And so there is emerging evidence that dupilumab can also be a very helpful tool in treating this. Moving on to another acantholytic disease. Fortunately, you're a woman with a long-standing history of benign familial pemphigus, treated with everything you can imagine that we typically throw at this. And so this is what she looked like when she came to see me. She said, I give up. Now, one of the things here, why it occurs where it occurs, is due to shearing and frictional forces and natural irritants, AKA sweat. And so there's growing evidence that onabotulinum toxin can be very effective in managing this. And for this patient in particular, which was rare, only monotherapy of onabotulinum toxin was effective at keeping her stable. That's a rarity. I usually still have to use all those other things. When thinking about that, we can use anticholinergics as well. Oral glycopyrrolate has been shown to be effective, but it has to be in the right setting and someone who can tolerate the side effects of xerostomia, dry eyes, things like that. But then you get these that you've, again, thrown everything at it or everything that you can actually access, and you kind of scratch your head and go, where do we go from here? That's when you go to the literature. That's when you Google or use Gemini or open access, or even ChatGPT, though hopefully it's telling you the truth. And that's where you'll find some random case reports. And so I found this case report, 2 cases of treatment with apremilast, which PDE4 inhibitor, okay, it does that, but maybe it doesn't do enough of it based on at least the responses of these 2 patients. So yes, it was 2 cases, so it's hard to really infer what that will translate in your practice, but I'm like, well, let me use the most potent PDE4 inhibitor available, and that would be oral roflumilast, which is approved for COPD, and this patient responded very quickly and continues to be maintained on the lower of the 2 doses, 250 versus 500, and this is just 6 weeks, but she continues to do well. All right, let's switch gears to follicular, non-scarring and scarring alopecias. I know Dr. Armstrong gave a wonderful lecture earlier today, so I'll try not to be too redundant. When we think of the most classic form of non-scarring alopecia, that is going to be pattern hair loss or androgenic alopecia. I think this study is cited like 1 million times over because it was probably the largest systematic review looking at every study for everything you can do for male pattern alopecia. So we have to take that with a grain of salt because male and female pattern alopecia is not the same thing. But dutasteride reigns supreme, which I do use in men, more often than not more finasteride, but it depends on the situation. But you can see where orals and topicals kind of match up as best side by side as you can imagine. But the standard FDA-approved things do work. So this is a patient after 16 months, 1 milligram of finasteride, did pretty well, was very happy. Again, setting those expectations from day one. This is your garden. We're gonna help the grass grow. It grows slowly. So when I bring someone back 3 months later, I don't expect them to be better. I expect them to be the same, and that's what I say. I wanna put a pause button on this progressive thinning over time, and that's what we're gonna do. And then hopefully we can recoup hairs that were miniaturized and get them back to their original size. For women, we gotta do more. Finasteride 1 does not work, I use 5. Again, you can see it takes a long time. It is absolutely a journey. Oral minoxidil has gained a lot of attention recently, and we have some really good support out there, which I'll cite in a second, to guide how we think about using it, how do we screen patients for things if we're concerned about potential adverse events. What to know? Go low. I start in women 0.625 milligrams a day, that's a quarter tab. Men, I typically do 1.25. I go up slowly, especially for women, because the main side effect is hair growth, but not where you want it. So sides, little stash action going on. Not a good look. I have patients who don't care. They're getting their hair back and they do like dermaplaning, things like that, or use a fluorinathene to inhibit hair growth where they don't want it. It is cheap, it is accessible now. There was a shortage because everyone was trying to get it. The scariest side of a pericardial effusion has been dismissed, which is great, but I do occasionally see facial and lower leg swelling, so certainly have to bring that up. And even the elderly, not a ton of studies, but certainly I use it in my older patients as well. I'm a big believer that combination is king and queen. So I offer patients the limited options. We can do minoxidil, we can do a 5-alpha reductase inhibitor, or if you want to do everything and it works best, we do both. This patient was like, give me the works. Dutasteride 0.5, minoxidil 2.5, very rapid, very impressive changes. I do believe minoxidil makes the hair grow a little faster. I can't prove it, but that's just been in my own hands, I'm seeing that. Same, again, combo of dutasteride 0.5, minoxidil 1.25. 6 months later, we see significant improvement in volume. Now, some of you may have saw this study where they compared oral low-dose oral minoxidil versus the topical solution, and they said that they were equivalent. This is kind of my take on this. I don't buy it. I'm sorry, I just don't. And honestly, that's all. Let's say that is true. Getting a patient to use topical minoxidil twice a day is really difficult. There was a study by Amy and Michael that showed that if they get through 3 months of use, they're likely to continue. 3 months. Best of luck to all of you on that one. So much easier just to pop a piece of a pill. All right, let's shift to scarring alopecias, the spectrum of LPP and FFA. You heard about this earlier. We throw a ton at this, and we do have a war chest, all of which is off-label. Whatever you're gonna do systemically, high potency topical steroids, alternating with a non-steroidal is gonna be part of that. Intralesional steroids, not into the scar. Waste of time, because it's already a scar. At the boundary of hair and scars where you can inject, doxycycline and hydroxychloroquine have historically been what we use, and there's a lot else there that you can talk about. Interestingly though, in recent times, there's been some evaluation of, okay, well these are the things we've been doing, how can we evaluate if they really are working? And one way is, are patients staying on them? And if hydroxychloroquine is our first line, why are so many people switching off of it within 6 to 12 months? Follow up to that, again, a more recent study, same deal, showing success versus failures with the go-tos that we've been using. Now, the only thing we don't know from these studies is, were these patients on concomitant therapy? And that's where I bring this up. I would never give a patient one thing. Out the door, they're being put on multiple things. I will load them up as much as they're willing to let me. This patient was on alternating 400, 200 every day, every other day, low-dose minoxidil, doxy 40, topical steroids, and she did see improvement. So my question in those studies is, are we just looking at patients who are on monotherapy or are they on the works? And my guess is they probably were not on the works. But getting back to Dr. Rosen's statement about JAK inhibitors, I really think that they are going to play a big role in scarring alopecia. You can see this patient has been on so many different things. We'd stabilized her disease to some degree, but not great. Thrown a little UPA, 6 months later, significant improvement. Granted, that scarring we're not going to improve. We're really recapturing hairs that were on their way out. Graham-Little-Picardi-Lesor syndrome. Combination of LPP, lichen planus of the body, it looks like keratosis pilaris, non-scarring alopecia of body folds. Exceedingly rare, exceedingly recalcitrant to treatment. This was her regimen, and she was still active. She is now only on upadacitinib. Did amazingly well, impact on itch almost immediately, cleared her back, cleared her scalp, and has been just on monotherapy with occasional topicals here and there for months at this point. Next, CCCA. My first 2 points are, do not miss the sponge sign. What I mean by this is, with active disease, you are not going to see erythema, whether it be red, pink, purple, black. But my impression is, if you press on the scalp and it feels like a dry sponge, it is active. Also active about symptomatology, because it can be very symptomatic, and so ask about itch and pain. The other is, it is not their fault. These patients have been told for years that's because they used a hot comb, curling irons, whatever, it's their fault. It is absolutely not. There's a beautiful New England Journal of Medicine study showing this is a genetic disease, and this is connected to uterine fibroids. So the third point is, ask about fibroids in these patients. We have different tiers of therapies. It's not you pick one, is you throw it all on. This is, if any disease warrants dumping the kitchen sink out, it's going to be this one. So you have a lot of different options that you can certainly go through. I think it is important, again, to mention the genetic predilection and ask about family history. It is always a work in progress, and it's important to say that, and it's important to say that you're never going to get this 100% back. Something that's emerging, thinking about the genetics and thinking about what genes are inappropriately turned on. Well, I mentioned fibroids and the fibrotic pathway. Do we have medications that are anti-fibrotic? Yes, that's a trick question. Of course we do. Metformin has been shown to be a wonderful add-on, or in some cases monotherapy, low dose, 500 milligrams a day. The main side effect is GI upset, and when you start to get to twice a day, that's when it really starts to emerge. Switching to histiocytic diseases, granuloma annulare. For more isolated disease, topical steroids, so they don't penetrate really that well, so we tend to do more intralesional steroids. For more broader disease, we're thinking about antimalarials, or hydroxychloroquine gets a lot of mileage, doxycycline, dapsone, retinoids, nothing with a lot of really great evidence. So here's one study of 9 patients looking at different dosings of hydroxychloroquine, some of them pretty high, and with good results. I have used it. That's probably historically my go-to, and I probably still will use it given how easy it is to use, but some new things are coming down. So what about antibiotics? There's been some work looking at like combination antimycobacterial approaches. This is pretty onerous. I probably would save this as like a third line, but I wanted to include the dosing regimen for your own edification. But doxy surprisingly works in some cases. The problem is, and I've seen this, as soon as you pull it away, it comes right back like within days. So I've kind of been burned by that. So I'm not really using so much doxy, but more sarecycline because they can stay on it. So this was a patient who had limited disease on his hands, but was so distraught about the clinical appearance. And within 2 months, sarecycline based on weight, halobetazole combined with tazarotene, I mentioned steroids, retinoids can be useful, had complete clearance, and he's been maintained, actually now just on topical sporadic dosing throughout the week. He's off sarecycline. Dupilumab, no clue why this would work. This isn't really a T2 disease. This is histiocytic, but we have several cases here showing that it can be effective. And then, of course, JAK inhibitors. I'm not trying to play favorites, but certainly we are seeing impressive impact from the litany of JAK inhibitors we have available to us. And these are some images of different patients from several studies. And to wrap up, I'm going to finish with a crossover, given the thing about surfing, in a patient who had both GA and morphia. And when you see two diseases that shouldn't have anything to do with each other, you start to think, what's the common thread? And you pull on that thread. And that thread, no question, is going to be inappropriate JAK activation. There are probably other things, but when you search the literature, that seems to be the common theme. So when you see a patient like this, who has linear morphia extending over joints, your first thing is going to get them into physical therapy so they don't have permanent disfigurement and inability to use that limb. You're going to get an x-ray to make sure there's not malaristosis, changes to the bone that look like candle wax dripping down a candle. But then you're also going to think about reaching for your big guns. Now, when we look at the treatment algorithms, there really isn't a lot out there. Topicals, actually what has the most evidence is calcipotriene, not a steroid. I'm not going to just use it as monotherapy for limited disease, but it's definitely going to be part of my armament. So topical steroids, tacrolimus in between, calcipotriene, my go-to initial regimen is going to be your combination, alternating with tacrolimus, and repeat, repeat, repeat. This actually, we're talking about Delgo all weekend with the new approval, but I'm focused on the off-label use, possibly for localized scleroderma amorphia. To wrap up, let's focus on disseminated disease. Phototherapy, UVA does work, but it's very limited in terms of where you can access it. But it's been shown that narrowband is probably equivalent to medium energy UVA. So if you have a light unit, this could be something helpful. Looking at hydroxychloroquine, I throw this on every patient, but I've never found this as monotherapy to be successful. You need something else. Methotrexate probably has most evidence, but it comes with a lot of baggage in terms of serial monitoring with labs, as well as potential side effects. Mycophenolate mofetil is like a soft immunosuppressant. I probably use this more than methotrexate, but also has been shown to be successful, and I have used this. Cyclosporin rapidly improves symptomatology, but you can't be on it longer than 6 months to a year, so somewhat limited. And then, of course, to wrap up with JAK inhibitors, there is definitely emerging evidence that this can be useful. This was a case with upadacitinib with refractory morphia, and I'm going to finish with this case in this patient who, if you just looked at her, you wouldn't even notice it. This is where palpation is so important. Rock hard plaques all over lower legs and buttocks, absolutely miserable, failed multiple immunosuppressants at 30 milligrams a day, calcipotriene, in just 3 months became soft. She used to say when she sat down, it felt like she was sitting on gravel. That abided. So I hope my enthusiasm for off-label use has somewhat been contagious, like some of the things that are floating around here, and that you too will be an off-label outlaw. Thank you.